glaucoma. So basically, primary open-angle glaucoma, the pathophysiology is still unknown. And from fundoscopy, we can see two main findings. The first thing we need to highlight is the disc and also the cup. And the second thing is on the vessel. So this is one of the photos of primary open-angle glaucoma and a few findings of it. So one very important sign is that it'll have a large cup to disc ratio with a thin neuroretinal rim, as you can see on the diagram. The disc is actually pink in color, but then there's expansion and increasing in the diameter of the cup covering over the disc. And also you'll be able to see laminar dot sign. Maybe you need to zoom in by yourself to see it more clearly at the cup region. So this is actually because of apoptosis or necrosis of the retinal cell ganglion, leaving the substance behind. And third thing you can see over in this photo is peripapillary atrophy, which is in the alpha zone. So peripapillary atrophy, you have alpha and also beta. Alpha is darker in color, whereas beta is more whitish in color. Later I'll show in another photo. And if you have beta peripapillary atrophy, it carries a worse prognosis, which means glaucoma will most likely progress to a worse stage in the future. So the second thing we need to look at is a vessel. Vessel, as we can see, there is a bean pot sign. So this bean pot sign is actually when you look under the fundoscope. Later I'll show you a more clear illustration of how it is formed. Because the cup is enlarged, so the vessels will be also pushed towards the outer rim of the cup. Right, next slide. So this is a clearer illustration of the bean pot sign. It is actually a description of acute turning of an angle back towards the optic disc after it left the retina. So basically a cup is enlarged, so it will put on pressure and the vessels will be compressed downwards, so it will form a bean pot sign. Right, next. Right, so this is the diagram to illustrate the progression of primary open-angle glaucoma. So as you can see over the years, this is from the same patient. The first thing you can note from the optic disc and cup is the cup and disc to disc ratio has already been increasing over the years. So probably in the first photo you can see is a 0.2 cup to disc ratio. The second photo probably 0.4. The third photo will be 0.6, and the last photo will be 0.9. And as you can see, there's also at the last photo, I'll just point out on the last photo because it's the most progressed type of primary open-angle glaucoma. You see there is a formation of collateral vessels at the yellow arrow, and because this is from the same patient, you can actually look at the differences among the pictures. So, and also there is a vessel nasalization where the vessels are all pushed to the nasal side. In this photo, is a little bit hard to determine the nasal and also temporal because we cannot see the macula. But then a vessel nasalization is one of the features in the fundoscope of POAG. Next slide. So there are a few more other features of POAG on the fundoscope. The first one will be this hemorrhage, as you can see on the left photo, on the first photo. And on the second photo, you can see two things. One of which is a peripapillary atrophy, beta. And in this photo, actually, there is both beta and also alpha peripapillary atrophy. You can note the color difference surrounding the neuroretinal rim or the disc. There's two kinds of color. One is more whitish, more pale. The other one is darker. The darker one is alpha. And there is also notching of neuroretinal rim. If you can see clearly, I don't know whether you can see clearly because in this photo is the color contrast not so well. And so on the right side, I listed down the important features under fundoscope which would appear inside primary angle closure, open angle glaucoma. So for this and cup, I've told you just now a few signs, and also for vessels, you need to look at two things. Right, next. Next, I will go forward to diagnosis of POAG. Mostly from a history, we need to ask about visual symptoms, which is normally absent unless it is quite advanced. There's glaucomatous damage already in the eyes. And there might be symptomatic central field deficits at an early stage. And next, we need to ask about the previous ophthalmic history, which whether the patient has any refractory disorder, including myopia and also hypermetropia, because myopia will increase the risk of POAG, whereas hypermetropia increases the risk of primary angle closure glaucoma. And you need to rule out any other causes of secondary glaucoma, such as ocular trauma, inflammation, maybe previous eye surgery, and other things that would affect the intraocular pressure. And the third one will be family history. Family history, you need to ask whether there is a family history of primary open angle glaucoma or any ocular hypertension and other ocular diseases. For past medical history, you need to ask the conditions which contraindicates the use of beta blockers, because beta, as we know, there are four kinds of main drugs used in glaucoma. Beta blocker, because beta stimulation is associated with increased secretion of the aqueous, and alpha is associated with inhibition of secretion of aqueous. And we need to rule out, or we need to ask the patient whether he can use beta blockers, especially in some conditions like asthma, heart failure, or perivascular diseases, which contraindicates the use of beta blockers. And the next one will be optic atrophy or visual field defects causes, including any maybe stroke or heat injury, and also conditions with vasospasm like migraine. And the third one will be chronic diseases, diabetes mellitus, hypertension, CVS. They will also increase the risk of POAG. And last one would be oral contraceptive pill. If there is a long-term use of oral contraceptive pill, it will also increase the risk of a POAG. And the fifth one I've mentioned just now, beta blockers, you need to ask for drug history and also steroids. Whereas for social history, you need to ask for smoking and also alcohol. And the last one, you need to ask for allergies if there's any drug allergies. All right, next I'll pass on the stage to Amirul.
Okay, so in the case of primary open angle glaucoma, there's a few investigation that we can do. So in terms of examination that we can do is actually for visual acuity, because if there is a late stage of the open angle glaucoma, there would be visual disturbance, which could be reflected by visual acuity. So it also is one of the easiest thing to do. So we just have the patient sit 6 meter away from the silent chart and ask them to read from the top. Then we go progressively downwards until the patient does not see, just cannot read the silent chart anymore, and then record the finding. Next, we could examine the pupil to see if you can also use fundoscopy in these cases. So you can also see the retina. Next is color vision assessment. However, this is indicated if there is suspected optic neuropathy. Okay, and also slit lamp examination. Here's the picture below. It's actually what they call as tonometry. So tonometry is to measure the pressure. This is important because open angle glaucoma. Actually the main idea of treatment is actually to decrease the pressure within the eye. So tonometry can help you determine what is the baseline and also how does the condition is either improving or not improving. Next, we have gonioscopy. So gonioscopy uses the gonioscope. This is to assess the trabecular meshwork because in the case of open angle glaucoma, there is an open angle. However, there might be damage or problem with the trabecular meshwork that causes the fluid to be accumulated and not what we say as drain into the nasal. Next is the optic disc examination. So optic disc examination, you just look like what you should look for what Yijing just described before. Next is continue.
Sorry to interrupt. Just now when you say investigation, we can straight go to investigation of glaucoma. Okay, the one yang optic disc, tonometry tu semua it comes under examination. Visual acuity ni semua kan. So when what I want to say is investigation, you straight to macam visual field test. Kan? Visual field test, OCT, macular head. Ada tak lepas ni? Yang imaging ni okay, pachymetry betul. To measure the cornea thickness. Okay. And then visual field mana visual field? Tak ada.
Tak ada doktor.
Ini. Okay, to everyone, the most important investigation in glaucoma ada yang paling penting bila lecturer ask, you say is a visual field. Dia mesti nak dengar visual field. Visual field ni is a objective test. Is a functional test. That means glaucoma ni dia ada structural problem dengan functional problem. Structure macam Eugene mention tadi pasal optic disc abnormalities, kita boleh detect there. Itu structural abnormalities. And then kita nak support diagnosis glaucoma ni dengan buat visual field test. Nanti go back, nanti buat homework tengok what is visual field test in glaucoma. You kena ada visual field test untuk diagnose glaucoma. Okay. Dia ada specific pattern semua, you need to go through. Lepas tu, the next thing is OCT yang you tulis tu, optical coherence tonometry. Kita tengok dekat mana ada satu mesin ni dekat klinik. Dia boleh measure optic disc dengan optic cup tu, dia boleh measure berapa. And then dia boleh kira fiber mana yang loss ataupun thinning tu dekat which area. Kita boleh document yang tu, boleh support punya diagnosis kita. Okay, yang anterior chamber depth measurement ni semua tak perlu. Ultrasound, stereo disc photography, okay, you can say. Okay, pachymetry pun okay. Kenapa pachymetry ni? Sebab pachymetry dia ada related dengan IOP kita. Okay, bila kita measure IOP tu, kita tak tahu is it a true reading or a false reading. Sebab every patient is different, they have different corneal thickness. So pachymetry ni, dia akan nak measure corneal thickness ni ada related to IOP. Yang ni advance sangat, tak expect you all to know and to learn in detail. Okay, and then can you go back to Eugene punya slide tak?
Yang mana doktor? Yang ni ke?
Yang the yang ni the first one ada bin sign tadi.
Ni doktor.
Bin port sign ni dari mana Eugene? Dapat dari mana?
Dapat dari lecturer. Sebab dalam buku dia bukan guna import sign, dia guna term yang lain.
Term apa tu?
Term
Bayonet ke?
bionetting.
Bayoneting lah. Okay, so this bin pot ni lecturer bagilah.
Ya.
Okay, then you follow. Okay, just to alert you ada bayoneting sign juga. And then lamella dot sign. Okay, this one okay. Large series ratio. Okay, everyone clear ke mana cup, mana disc? Can someone point with the pointer to show me where is the cup and where is the disc? Okay.
Yang tengah ni cup doktor.
Alright.
Yang lagi cerah ni, lepas tu yang besar ni dia disc. So cup ada dalam disc.
Okay, good. So the normal cup disc ratio is?
0.4, 0.3 kan doktor?
Okay, and this case berapa cup disc ratio?
Nampak macam 0.8 or to 0.9.
Okay, very good. Okay, alright. So future, I think the next presenter onwards, I just nak gambar this signs and then you go back to your investigation slide. Okay, investigation. Okay, then lepas ni ada apa? Slide. Management. Okay, continue.
So continuing to the principle of management. So the principle of management according to the CPG is to actually, according to Kansky, is to prevent functional impairment of vision. This is done by slowing the rate of the ganglion cell loss. Also, you need to monitor the progress of treatment and the progress of the glaucoma. It is mentioned that lowering the IOP will actually help decrease the risk of progression by 10% for each millimeter mercury from the IOP baseline. So you get the baseline from the first time you see the patient, and then the subsequent visit you see how much that the decrease of IOP from the treatment has done. So the treatment option for medical is for prostaglandin analogs, beta blockers, adrenergic agonists, carbonic anhydrase inhibitors, cholinergic agent, and osmotic agent. For laser treatment, what is available is laser trabeculoplasty and also transscleral cyclophotocoagulation. For surgery is trabeculectomy, lens extraction, and glaucoma drainage device.
Principle management, basically kita prevent visual impairment. Okay, and then monitor progress. Okay, lowering the IOP. Okay, then you can say the management can be divided into medical and medical, laser, and also surgical treatment. Okay, this is a good slide. Okay, next. Alright. Just a simple picture, investigation, management. Kita nak simple so that you all, I think fokus pun dah makin kurang sebab dah banyak dengar lecture kan. So kita nak you get the get the points straight and then remember. Okay, continue.
Assalamualaikum and a good morning everyone. So me, Aini and Elia will present about traumatic optic neuropathy. So next. So traumatic optic traumatopathy follow ocular, orbital or head trauma is a sudden visual loss that cannot be explained by other ocular pathology. It occurs up to 5% of facial fracture. So classification terbagi pada dua, direct dan indirect. So direct due to blunt or sharp optic nerve damage from agents such as displaced body fragment ataupun local hematoma, and then a projectile, and then secondly indirect, in which force is transmitted secondary to the nerve without apparent direct disruption due to impact upon the eyes, orbital or other corneal structures, which is indirect ni adalah commonly occur lah instead of direct. And then mechanism include contusion, deformation, compression or transection of a nerve, intraneural hemorrhage, shearing, secondary vasospasm, edema and transmission of a shock wave through the orbit. Doktor? Doktor? Saya jumpa gambar CT scan of the orbit je doktor. Saya tak jumpa fundus dalam buku Kansky ni.
Okay. Alright. So basically, traumatic optic neuropathy, as the name suggests, the trauma kan. Basically, bila patient ada many facial fracture, dia ada accidents to the head, dia ada facial fractures, the bones boleh impinge pada optic nerve, causing optic neuropathy. Okay. The other mechanism macam like you mentioned just now tu kan, dia boleh from a blunt trauma pun boleh. But most kita boleh nampak sometimes shuttlecock injury pun boleh dapat. When you play badminton, shuttlecock hit directly onto your eye. And then, but mostly in hospital kita nampak bila dia ada motor vehicle accidents. So bila kena kat mata, the force tu akan menyebabkan yang macam you mention tadi pathophysiology dia. So fundus picture dia is basically normal. Tapi signs yang kita pick up ada, you ada pick up signs tak? You ada find out what are the signs of optic neuropathies. Tu yang kita nak you dapat. Alia yang nama. What are the signs of optic neuropathy? Traumatic optic neuropathies? Signs dia basically, sometimes patient, kalau patient tu aware, dia punya visual acuity memang very bad. It can go down into hand movement ataupun counting fingers. Secondly, most of the patient datang dekat kita is already intubated, GCS low, so they don't respond to the visual acuity test. Jadi kita buat RAPD. RAPD positive traumatic optic neuropathies. Okay, RAPD positive in a traumatic case with facial fractures equals to traumatic optic neuropathies. Okay, itu I nak you simpan dalam kepala. It's important sebab kita perlu intervene dengan management. The signs lain tak ada, just RAPD positive, then you can't check the other optic nerve function test like you learned before. Macam color test, rate saturation, light brightness, tu semua kita tak boleh check kalau patient tu tak aware. Jadi the only sign that we can pick up dekat emergency atau red zone, yellow zone is RAPD. Your RAPD dengan when you see the fundus in acute stage traumatic optic neuropathies will have a normal fundus. Okay. Some patient yang datang lambat, some patient boleh dapat pale optic disc. But usually that is later bila you review the patient dekat ward after 2 weeks or few months, then you nampak patient punya optic disc akan pale. Okay. So okay, CT scan ni you can't see it's a traumatic optic neuropathy, is a clinical diagnosis. Okay, you tak payah diagnose based on scan. Scans ni it can show kalau ada fractures atau ada bony impingement dekat optic nerve tu, yes, kita minta kita akan minta referral untuk remove the bony fragments tu. Kita akan refer, is another surgery. Okay. Alright, next slide.
Okay, faham doktor. Thank you doktor.
Oh, ada dah ni.
Okay, Assalamualaikum doktor. Sorry doktor, I will proceed with the next thing. So as Dr. mentioned before, the sign of the traumatic optic neuropathy is the patient must have sudden reduction of vision with only perception of light after blind or penetrating trauma. Secondly, patient will have FLM papillary defect, which is the pupil will be dilate when RAPD test will be done. And the last one is optic nerve head and fundus are initially normal, but after that we become paler, develop over subsequent days and weeks due to avulsion of blood vessels supplying the optic nerve. So next slide. So moving on to the investigation. First is CT scan. It is more effective in the demonstration of the bony abnormalities such as optic canal fracture. And secondly is MRI for soft tissue changes such as hematoma.
For the diagnostic investigation, first is visual acuity assessment. Second, pupil examination. We use RFPD test. And the last one is fundoscopy examination to look for any changes in the fundus, which is pallor in the fundus. And the last one is other tests, could be visual field perimetry, visual evoked potential, which is can be helpful in unresponsive patient or in cases with concomitant ocular injury. And the last one is retinal nerve fiber layer imaging to assess and monitor for the nerve fiber layer axonal loss during the period of follow-up. And the last one is for management. First is we give the high dose steroids within hours, which is IV methylprednisolone. Second is optic canal decompression, such as endonasal and transethmoidal. These two management is to improve the visual loss to the patient. And the last one is optic nerve penetration. That's all from me. Thank you.
Slides. Simple. Tak lah, you dah ada semua ni, patut you mention lah tadi. Okay, continue.
Okay, Assalamualaikum and good morning to doctors and fellow colleagues. So we continue to next topic, which is posterior uveitis secondary to tuberculosis. So basically TB is a chronic granulomatous infection usually caused by Mycobacterium tuberculosis. It is primarily a pulmonary disease that may spread by the bloodstream to other sites, and one of them is ocular involvement. It can either occur as a primary active infection, usually at the conjunctiva, cornea, and sclera, or a secondary infection from a distant site. Ocular features secondary to TB are not limited to only posterior uveitis alone, but can also manifest as anterior uveitis, vitritis, retinal vasculitis, conjunctivitis, and so on. Okay, next slide. Just a brief on the risk factors and the clinical findings. Certain risk factors that predispose individuals toward intraocular TB include immunocompromised patient from chronic disease, HIV infection, or use of immunosuppressant drugs. Recent immigrants from endemic areas and also history of contact with TB infected personnel also are the risk factors for patient to get TB infection. As for clinical findings, it is important to note that the clinical findings are not limited to intraocular signs only, since TB is a systemic disease with multiple organ involvement. Thus, as a practitioner, we need to elicit the classical sign of TB, such as fever, night sweats, and loss of weight. And commonly, the reported symptoms, ocular symptoms, are blurring of the vision and light sensitivity. Other complaints may include headache, redness of the eyes, floaters, and also flashes. Okay, next slide. So, ocular signs that suggestive of tuberculous posterior uveitis are listed here. It can be unilateral or bilateral. The three fundoscopic patterns are solitary tubercle, miliary choroidal tubercles, and also tuberculoma if it goes untreated. So as shown in the diagram at the top right corner, these are examples of miliary tubercle, small multiple millet seed size and yellowish lesions at superior temporal. And tuberculoma can be seen in this fundoscopy as well. The other ocular manifestation of TB is serpiginous-like choroiditis. It is a multifocal lesion that progress in a serpiginoid pattern and coalesce. The diagram at the bottom right shows a highly pigmented multifocal lesion in serpiginous pattern. Okay, next slide. These are more examples. The first fundoscopy on top left shows a poorly defined border of yellowish lesion, which suggests a tuberculoma at the superior temporal, and the diagram below that is shows a serpiginous hyperpigmented multiple lesions. And then at the center, again, tuberculous granuloma and a diffuse infiltration of granuloma can be seen in a patient with AIDS. And on the right side, the top right fundoscopy shows a clinical appearance of serpiginoid tuberculous choroiditis with a granuloma, which can be seen at the superior part. When fluorescence angiography is done, areas of hypo and hyperfluorescence can be appreciated, as shown in the diagram in the bottom right. Okay. Next slide. So the diagnosis of ocular TB. Sorry, doctor.
Go back to the previous slide. Okay, good. This is a good image of all the posterior fundus findings in TB. But the basics you need to know is that uveitis, you will expect to see a choroiditis ataupun retinitis. On the picture top left tu kan, the white patch over the supero-temporal area tu kan. So kalau you as a student, you can say, okay, this is a whitish ataupun yellowish lesion about 1 this diameter, 1.5 this diameter located at the supero-temporal arcade. Okay, possible is choroiditis ataupun retinitis. And then examiner will ask, okay, how you differentiate choroiditis and retinitis? So can you appreciate that ada blood vessel yang goes above that white patch tu kan? So if the lesion is under the blood vessels, it's a choroidal lesion. So this is choroiditis. Okay. Kalau retinitis, dia dekat more superficial, dia akan tak nampak that blood vessels. Okay. So just to highlight that lah, macam these are all image memang classical lah, but kan sometimes we don't see this choroidal tubercle selalunya. Biasanya kita akan dapat just a choroiditis, retinitis, vasculitis. Okay. Alright. So anything in this picture yang anyone tak clear or nak tanya tak? Tak ada Okay. I think untuk gambar C, gambar top, bottom left tu, bottom left hand side tu, yang ni bukan typical this is quite rare. Kita nampak yang ni I think is a serpiginous choroidopathy. Bottom left. Dia ada nampak macam scar tu kan. That is a serpiginous choroidopathy. Yang ni rare. Okay. Okay, alright. Next slide.
Okay, doctor, thank you. So again, the diagnosis of ocular TB requires a combination of history, clinical examination, and adjunct testing. So the definitive diagnosis of TB is established by isolation of Mycobacterium tuberculosis bacilli from ocular tissues, but this is not always possible. Thus, the diagnosis is often presumed in the presence of suggestive ocular findings in combination with any of the following. First one, systemic findings consistent with TB infection, such as evidence of pulmonary or extrapulmonary TB. And then positive interferon gamma release assay, which measure a person's immune reactivity to Mycobacterium tuberculosis. And lastly, a positive tuberculin test, tuberculin skin test in asymptomatic individuals. And in addition, a clinical response to anti-TB treatment further support the diagnosis of ocular TB. Okay, next slide.
Okay, for the investigation, we can do the microbial or histopathological evidence, which for the MTB, which is acid fast bacilli or direct smear on the culture of the MTB for the ocular samples. And other we can do is the tuberculin skin test, which is used to assess immunological evidence of MTB in the latent or the active phase. And we can also do the IGRA test, which is the two single visit blood test, which is quantify the FN gamma, which is to respond of the T cell after in vitro stimulation of patient lymphocyte by the TB antigens. Moreover, we can also do the PCR test and test X-ray, which is evaluate the and to suspect the intraocular TB and suspect that lung are the primary site of the tuberculosis infections. And other more we can do is the like in previous slide, which is the fluorescence angiograph, which is to evaluate the retina vascular leakage and active the and for the choroidal lesion. And for the ultrasonography, it can reveal the moderate to the low internal reflectivity of the large tuberculomas. And patient diagnosed with active tuberculosis should also be tested for HIV, which is due to high incidence of the co-infections. And also is the one of the risk factor. Okay, next for the treatment.
Just want to ask for that Mentux test, right? What is the normal? What is the normal value of Mentux test?
Less than 5 mm.
Less than 5, is it?
Yeah, yes.
How about people who are at high risk?
Oh, people at high risk with the Mentux test.
So if it's more than usually Mentux test is positive if it's more than 15, but if let's say for high risk people like HIV, if it's more than 5, it's considered positive. Okay.
Okay.
Proceed.
Thank you. Next. Okay, for the treatment, we can give a multi-drug therapy, which is four of the common drug, which is prescribed with the specialist in the systemic tuberculosis management. If ethambutol is used, monitoring for optic neuropathy should be take place as it have a side effect. And rifabutin also can cause the anterior uveitis, which is non-adherence to treatment. Non-adherent to treatment is common. So others can use the topical systemic steroid, which may be used in the concomitantly to release inflammation induced damage, particularly in the early weeks of the treatment, when they may have retard for slow worsening of the fundus appearance. So laser may be applied for the ischemic retina for the pre-retinal neovascularizations. And that's for the treatment.
Okay, so I'll continue with the papillary edema secondary to pituitary edema. So what is papillary edema? So as the name implies, actually if you see edema, so you think of swelling, right? So papillary edema is actually swelling of the optic nerve. However, it must be due to increase in intracranial pressure, because if there is any swelling of the optic disc, but not because of raised ICP, it is called disswelling or dysedema. So there are many causes of increased ICP, such as any tumor or space or pain lesions. So decreased CSF resorptions, such as from venous sinus thrombosis, increased CSF production, obstruction of ventricular system, idiopathic intracranial hypertension, or as well as from medication. So I will be showing pictures of papillary fundus of the papillary edema, because I couldn't find any better fundus finding of papillary edema due to the pituitary adenoma. However, my friend will touch on the specific a bit of specific on pituitary adenoma for the diagnosis. So next, please. So this is as you see from the left, that's the normal fundus. Okay, and as we all know, if you see a fundus pictures, you need to describe one. You look at the optic disc and the optic cup, and then as you know, the optic disc must be well defined margin, and the cup to disc ratio is about 0.3 to 0.4, and the optic disc usually pinkish with the cup more whiter compared to the optic disc, and you see at the center is there's like a darker section. And at the center is the darker section, as you can see from as you can see, so that's the macula, and that's the fovea, and and you can see of the vessel as well. So the veins gonna be darker compared to the artery. So that's the normal fundus side. So for the papillary edema, it was a grade with using the modified Pearson scale. So F grade until grade 5. So grade 1 is actually just a normal normal fundus, no finding. So for grade 1 with minimal degree of edema, the features that you need to remember is the C-shaped halo. So C-shape is actually from here. You can see macam C-shape kan. So the C-shape halo is actually it's called referring to the margin of the optic disc as well. Okay. So dia tak full kan. So dia just C-shape halo. So this is grade 1. So that's why the temporal disc margin is still normal lah. Sebab dia tak ada macam halo tu yang keluar-keluar hitam. And there's going to be also a disruption of normal radial fiber like arrangement sedation. Okay, so next, please. Itu punya annotate tepat. Oh, lama. Padam. So for low grade 2 or low degree of edema, so if you can see there's a circumferential halo. So dekat sekeliling tu dah ada halo. Okay. And no major vessel obscuration. So major vessel obscuration kita boleh tengok dalam grade 3. So kalau dalam grade 2 dia tak ada obscuration lah. So for elevation is actually we cannot see from the picture. Kena tengok dekat slit lamp sebab dia macam more of a 3D presentation. So kita kena tengok on slit lamp. Okay, and for elevation ni will be on nasal border. So doctor, actually I want to ask how will it be presented kalau dia kata elevation dekat nasal border? Maknanya dia the disc elevated at the nasal part tu macam mana?
Yeah. Kalau elevated dekat nasal side your question.
Yes doctor. Kalau dia kata nasal border maknanya dia elevated dekat nasal part lah ke macam mana?
Boleh sebab optic disc swelling ni dia can happen anywhere. Dia can be at the nasal saja, can be at the temporal saja. Dia takes time. Dia tak ada black dia tak ada black and white sangat lah. It can elevate anywhere. Kalau nasal saja you akan nampak nasal side tu je lah yang elevated. Soalan tak? Sarah, anything to comment? Sarah.
Yeah, sometimes in the beginning stage it will be nasal lah, but it's not like Abbas said, it's not black and white. We don't really bother so much about that lah. As long as there's elevation and then there is peripapillary hemorrhage, we will just go with the papillary edema.
Yep, agree.
It's not so specific lah. It's not that.
Thank you, doctor.
Okay.
So I'll continue for grade 3. For grade 3, there is a moderate degree of edema. So as I said earlier, in grade 2, there's no obscuration, right? So obscuration is when you can see the vessels actually macam hilang kan. It's disappearing. Dan tiba-tiba dia hilang masa dia nak masuk dekat optic, masa dia nak lift the optic disc ke. Okay, so as you can see, there is obscuration of more than one segment of major blood vessel. And there's going to be circumferential halo as well. And the elevation going to be on all border. And there's be like irregular outer fringe. Macam dekat luar tu macam ada outer fringe with finger-like extension. Okay, next please. So grade 4 is a marked degree of edema, as you can see dah nampak kan. So there is going to be a total obscuration on the disc. So the obscuration will be of a segment of a major blood vessel on the disc. Tengok. Okay. Macam lagi banyak, and they're gonna be elevation as well and border obscuration. So tak nampak sangat dah border kan. The border of the disk dah hilang, and then gonna be complete halo around the sekeliling border, sekeliling disk yang dah hilang tu. And then for grade 5, for severe degree, as you can see, memang kata total obscuration lah. If you see pun macam kita tak show where's the disk kan. So kalau kita tengok, kita trace the blood vessel, as you can see there's going to be total obscuration, dah tak nampak semua. So that's the fundus finding for papillary edema. So my friend will explaining about
I just want to add something.
Yes.
Yeah, you just now you were quite particular with the nasal swelling and all that, right? But in general, right, in real clinical practice, we don't. I mean, we of course we see where it is swollen, but the one of the important things that for it to be papillary edema, it has to be bilateral. That's one thing, and another thing is that the swelling. Apart from that, there will be peripapillary hemorrhage. In these pictures, I didn't notice any picture with peripapillary hemorrhage. And then sometimes you'll have some effusion near the macula. So basically, if it's bilateral, and when you see in the clinics or what, there is optic disc swelling, you can think about it. The grading is not it's not that important lah, but you have to emphasize that it is bilateral lah.
Thank you, Doctor. So next. Okay.
So good morning everyone to doctors and friends. So I'm going to present about the diagnosis, more of a sign and symptom in papillary edema and pituitary edema. Pituitary adenoma, sorry. So for sign and symptom for papillary edema, we can have raised intracranial pressure symptom such as headache, nausea and deterioration of consciousness. We also can have visual symptom such as transient visual obscuration, horizontal diplopia, and vision generally normal or minimally reduced. For pituitary adenoma signs and symptoms, we can have headache. Visual symptom may be vague. We have also color desaturation. So we can do color desaturation test, which we ask the patient to compare the intensity of red color. And then we have optic atrophy, specifically bow tie atrophy. So you can see the picture below I've inserted. This is an example of a bow tie atrophy picture that I found in Google. So from what I've read, bow tie atrophy is very specific sign, and then from bow tie atrophy, we can know there is lesion on the optic chiasm. And then lastly, in case of pituitary adenoma, papilloedema is rare, but it can still happen. Okay, next.
Wait. Okay, first of all, papillary edema punya symptoms tu, I nak dengar 3. Headache, nausea dengan vomiting. Okay, these 3 mesti ada bila you nak cakap patient ni ada ICP symptom. Okay, bila you club patient later on bila kerja, just make a habit high ICP symptom equals to headache, nausea, headache, vomiting dengan diplopia. Headache, vomiting and diplopia. Okay. The rest you can always tambah dengan CNS symptoms yang lain lah. Okay, visual obscuration ni okay, transient blurring of vision. Usually patient memang datang sometimes kalau nak cakap you can say blurring of vision dengan visual field defect yang kita nak dengar. Okay, and then this papilloedema, dia punya signs tu, yang color desaturation tu, okay lah, you can group bila you examine patient, you suspect dia ada papilloedema, you buat optic nerve function test yang you belajar tu. Okay, tapi dia punya, sebab dua-dua optic nerve dah impact, jadi sometimes you tak boleh dapat RAPD sebab RAPD you need satu mata teruk, satu mata okey. Kalau dua-dua sama teruk, then you can't get RAPD. Lepas tu color saturation, yes, sometimes you may get dua-dua mata color desaturate, tapi susah nak dapat. And then visual field defect. Kena buat confrontation test, then you boleh nampak visual field defect. And optic findings, macam you okay ni, papillary edema is rare. Okay, this one quote daripada Skansky
Yes, Doktor, from Kansky.
Okay, tak boleh nak cakap apa. Okay, alright, next slide.
Okay,
I just want to ask, any idea why there's horizontal diplopia?
so in this current slide, right,
Yes.
the left side picture, with the eyes and the brain. So horizontal diplopia occur when there is a lateral rectus muscle weakness. So what happened is the picture below, the skull picture. So when there is a increase in intracranial pressure, there will be the petrous tip of the skull will move downward. So what will happen is it will compress either one or both of the six cranial nerve, the abducen nerve. So when the nerve is compressed, it will cause cranial nerve palsy, which will cause the lateral rectus muscle weakness, and that's when we have horizontal diplopia. So the picture, the next picture is I want to show when there is a pituitary adenoma. So the pituitary gland will increase in the size. When the pituitary gland increase in size, it will compress the optic chiasm, and what will happen is it will compress the decussating fiber, and patient will have bitemporal hemianopia as the picture below. That's what I want to highlight in this slide. Okay, next slide. Next sekali lagi.
Yang Dr. Priya tanya tadi kan diplopia, why diplopia kan? Sarah, are you satisfied?
So you can go back to the previous slide. So
Simple answer
so-
tak?
the diplopia, right, is because of the sixth nerve, right? So when the patient present, when you see the patient, how do you think the eye will look? Where will the eyeball be deviated? It's the sixth nerve palsy, right?
Yes.
So where will where in primary gaze, where will the eyeball be?
Normal, Doctor.
Normal lah. If let's say you wrote the right lateral rectus weakness, right?
Okay.
In your slides.
Uh-huh.
If let's say the right eye has lateral rectus weakness, where the eyeball will be? Dia tak boleh abduct kan?
Dia tak boleh abduct.
So mata dia akan ke
kanan. Sorry.
So it will be inside, like it will be adducted, right?
Abducted.
Adducted.
Adducted.
Adducted, it will be inwards, kan? It will look like a ISO. Betul tak?
Uh-huh.
When you see the patient, right, he will look like as if he squint. Kalau sixth nerve palsy, the right eye, the eyeball will be deviated inwards towards the nose.
Okay, Doctor.
So when they move on extreme gazes, the eyeball doesn't move up. When they're trying to look at the right side, it doesn't abduct, so there'll be double vision because the right eye cannot move outwards. Okay, that's why they get that double vision lah. Okay. So when you have patient with bilateral eye optic disc swelling with one eye appears to be inwardly deviated, so that's also one of the clues for you to think that maybe there is a raised intracranial pressure apart from the symptoms. Okay, can proceed.
Agree, yeah, agree. And then I think lecturer would want to hear term ni, false localizing signs.
Yeah.
When you have a mass in your brain, it causes your intracranial pressure to raise. So when it raise, dia because sixth nerve is special, it has the longest course daripada brainstem to pergi mata, paling panjang. And then at certain area tu dia macam which area Sarah yang the one yang dia get compressed there?
At the petrous tip, yes. Just now he said.
Okay,
The petrous tip,
alright.
memang correct. But, yeah.
Okay, so because it's a false localizing signs, nerve get compressed, then you get diplopia. Okay, remember ni important. Okay, continue.
Okay.
And the
Slide.
bitemporal hemianopia, you can do the confrontational test. Yang tu tahu kan? In the clinic itself, you can in your, let's say you are in a clinic kesihatan, you can elicit it with confrontation test. You all know how to do confrontation test kan? Tahu ke? Tak pasti ya.
Tak pasti sebab tak pernah buat.
Oh, tak pernah buat confrontation test ya? Oh, okay. Never mind. In the clinic, you learn lah later. Okay.
Right. Next slide. So these are the investigation that should be done. So first, when we have patient with papilloedema, we should do B-scan ultrasonography. So B-scan ultrasonography is to investigate the posterior eye. In this case, we want to rule out, we want to distinguish and to rule out pseudopapilloedema. So we want to make sure if the patient have papilloedema or pseudopapilloedematous. Pseudopapilloedema. Pseudopapilloedema is
Irfan. So
okay.
I want everyone to know. First investigation when you have a papular edema, the answer you should give is I want to do an imaging in a form of CT scan ataupun MRI brain. Okay, B scan ultrasound ni it's advanced. Tak apa, you tak perlu jawab sebab dia advance, dia macam it's too detail. First papular edema, kita takut space occupation, you jawab imaging of the brain in a form of CT scan or MRI. Okay, B scan ni you tak payah mention unless sebab B scan ni yang pseudo papular edema ni dia very rare. Pseudopapular edema ni macam optic extrusions and all kan, I don't think you pernah dengar. So yang tu itu je yang dia boleh differentiate. So we don't commonly perform B scan in a papular edema patient. Alright, so the answer should be imaging of the brain, CT scan or MRI according to, depending on the availability. Okay, and then of course itu je lah, imaging je sebenarnya. Alright.
Okay, thank you, doctor. So for investigation, we do MRI to exclude space occupying lesion or enlarged ventricle. In this case, we have space occupying lesion, which is the pituitary adenoma. But if there is no space occupying lesion or no enlarged ventricle, we need to think of other diagnosis. What caused the raised intracranial pressure, which are some of the differential diagnoses are idiopathic intracranial hypertension or impairment of CSF reabsorption due to meningitis. It is in Kansky, it is wrote that we need to do lumbar puncture only if when there is no space occupying lesion or no enlarged ventricle. So we want to know if the increase in intracranial pressure is due to meningitis or not. So we do the lumbar puncture. So for next, for the pituitary adenoma, we do magnetic MR with gadolinium contrast to using multiple plane, or we use CT to see the enlargement or erosion of the cella. So I've put a picture on the normal pituitary gland and then the pituitary adenoma, which is we can see there is increase in size. Next slide. Okay. So for the management, for papillary edema, we need to treat the underlying cause and surgically remove any lesion if there is any space occupying lesion. So for pituitary adenoma, in this presentation, the cause is the pituitary adenoma. So in pituitary adenoma, we use medical therapy to reduce tumor size, such as cabergoline or osteotrite.
I just want to ask this cabergoline octreotide untuk apa
Reduce tumor size, doktor.
Reduce tumor size ke, betul ke?
I'm not sure. I take from the Kansky, doctor.
Okay, anyway, this pituitary adenoma, right? Just now you were saying about symptoms, right? Pituitary adenoma itself, what kind is there any other systemic manifestation that you can think of? What does pituitary adenoma cause to the body?
There is a lot of systemic symptoms.
Yes.
Such
What is it?
as
Pituitary gland, what is the
yes,
function of pituitary gland?
maybe in female patient it will cause menstrual irregularities.
Yes. Okay, very good. Why is that?
Because the pituitary gland secrete GnRH.
Is it only? I mean, pituitary gland has a lot of.
A
You've
lot
got A
of.
and B, right? So I
Yes.
mean, is it sexual hormones only? Is it? No other hormones, is it, in the pituitary glands?
No, there is other hormones.
Which is?
Which is
corticosteroid as well.
Very good. Some more?
Prolactin.
Okay.
And then
somatotropin. And then TSH and all that, right?
Yes.
So when you have pituitary adenoma, you have hormonal changes in your body. So it will be manifested systemically. So if you have, for example, prolactin, you have the prolactin. If the prolactin is raised, you will have galactorrhea. In male or female, you have galactorrhea, amenorrhea in female, and also gynecomastia in male. So if they have increase in somatotropin, what will be the findings? Increase in somatotropin. Any idea? Anybody knows what will happen? So if somatotropin is increased, in children they'll have gigantism, and if in adults they'll have acromegaly, right? So that's why you have to refer this kind of patient to the endocrine, and then they will start medication to reduce these hormones. Okay. So this octreotide cabergoline is to combat these hormonal issues. Okay, can continue.
Okay, thank you, doctor. So the next thing we can do is surgical therapy to remove the tumor, and then radiotherapy is rare due to its complication, which is death of surrounding brain tissue. And then the last thing is we need to monitor with long-term ophthalmologic review with serial assessment. We need to monitor if the visual function of the patient in this case. So I think that's all from me, doctor.
Okay, good presentation. A very important topic, papular edema. And also Dr. Sarah mentioned the systemic manifestation of papular edema is important, gigantism and all, because you can get these kind of cases during your long case. Okay, this is a very special and a good case to discuss. Okay, all right.
Thank you.
Okay, so Assalamualaikum and good morning. So I will continue with retinoblastoma. So for introduction, retinoblastoma is actually a malignant tumor in the retina and it's rare but most common primary ocular malignancy in childhood and is second most common intraocular tumor. And there's two types which are non-hereditable and hereditable and it's actually occur due to mutation or defect in RB1 which is a tumor suppressor gene at the chromosome 13. So next. So for the first picture, just want to say the difference between the healthy eye and the large eye receive light or informations. So healthy eye, you can see that all the lights are touching the retina, but if the patient have small retinoblastoma tumor, some part of the information or the light cannot touch the retina due to the tumor. And if there is a large or retinoblastoma tumor, there's no light can go to the retina. For the picture right above, it's actually a tumor that can see in the eyeball. So it's an endophytic retinoblastoma, which is the tumor grows into the vitreal cavity. And the below one is a imaging result that show a tumor in the right eye. Okay. Next. So for the left one, we can see the left and right eye is a retinoblastoma retina scan that can see before and after chemotherapy where the reduction of the size of the tumor. For the above, the image of the fundus in solitary unilateral retinoblastoma and the macroscopy image of the exposed eyeball in advanced multifocal retinoblastoma with extensive vitreous body dissemination. And the below picture is we can see that the patient from the left one have developed a sign, but when there's delay in diagnosis or delay in seeking treatment, it can be progressive and protruding like that. Doctor, I cannot find any picture of fundus with specific fundus pictures of the retinoblastoma. So
Yang
next.
semua ada tu. That's the you have put up picture. What is okay? The picture is okay.
It's okay. Okay.
It's okay.
So next. So for diagnosis, we can diagnose retinoblastoma by history taking. The most important is family history. So we want to know if it's a heritable or not, and then do physical examination or also imaging. But for the retinoblastoma, we doesn't need biopsy. Okay, presentation is within the first year of life in bilateral cases and around 2 years of age if the tumor is unilateral. So what are the signs we can see is leukocoria, which is the commonest presentation, strabismus, red and irritated eye, blurred vision, proptosis, and it can cause secondary changes to eye, including glaucoma, retinal detachment, and inflammation secondary to tumor necrosis. And orbital invasion or visible extraocular growth may occur in neglected cases. Okay.
So next, I will proceed with the investigation. So actually, the aim of the investigation to confirm the diagnosis and to establish the presence and extent of the extraocular spread. So we have red reflect test, corneal light reflect to look for the strabismus, and then can do the eye examination to look any structural abnormality. Then the dilated fundus examination. Next is the ultrasound, which ultrasound can help to define the height and thickness of the tumor. So apart from the ultrasound, we have CT scan or MRI. So CT scan is best avoided as any dose of the radiation may magnify the risk of developing the secondary malignancy. So MRI may be useful if there is suspicion of extraocular, particularly intracranial spread. So especially with the child that present with signs of intracranial pressure, such as to look for the pineoblastoma. And then you can do the blood test to check for the tumor marker. Then can do the bone marrow aspiration or lumbar puncture to check for metastatic disease. And lastly, can do the immunohistopathology staining. So specifically for the retinoblastoma, there will be fractional winter staining rosette. So then for the management of the retinoblastoma, the aim is to complete control of the tumor and the preservation of as much useful vision as possible. So first is the focal treatment, which it is used for small tumor, usually in patients with bilateral disease, and usually is used in combination with the chemotherapy. So A is the laser photocoagulation. It is recommended only for the small posterior tumor, uh, where a laser is used to hit the tumor. So two or three monthly sessions are usually required. So B, we have cryotherapy, where the technique is by freeze the tumor. So cryotherapy may be used as primary therapy for the small peripheral tumor or for small recurrent tumor that previously treated with the other method. And then cryotherapy also can be used to treat the anteriorly located tumor. So C, we have thermotherapy, which involve the application of heat directly to the tumor, usually in the form of infrared radiation. Then next we have chemotherapy, where usually used for the metastatic disease. And then there is radiotherapy, such as external beam radiotherapy, but it is mainly a salvage method for the eye that have failed to respond to chemotherapy and focal treatment, since the radiation therapy may increase the risk of secondary malignancy in retinoblastoma survivor. And then we have in the advanced cases, such as the tumor is too big or the vision had lost, so we might do the enucleation. So lastly, there is genetic counseling should be offered, and the children whose parents have had an retinoblastoma should be assessed from the infancy.
Okay, quite good. So basically, do you guys know whether it is hereditary or sporadic retinoblastoma? Okay, so most of the time, retinoblastoma is sporadic, but there are familial trait to it. So when you have a patient who has retinoblastoma, you have to screen the siblings and the parents as well, and screen the siblings, like especially. So the most important thing is the leukocoria. So when there is a white reflex from the ophthalmoscopy, you have to be alert, and that is one of the very important differential diagnosis. And sometimes they can come in advanced stages, but most of the time, it's important to detect them at the earliest stages. Okay, so I can go to the next case.
Okay, Assalamualaikum and good morning. Me and Hazira will proceed with age-related macular degeneration or ARMD. Okay, ARMD is a degenerative disorder affecting the macula, and it is characterized by the presence of specific clinical findings, which mainly include drusen and retinal pigment epithelium changes in the absence of another disorder. Okay, next. Okay, ARMD is divided into two main types, which include first dry and wet. Dry is the most common form of ARMD, and wet is much less common compared to dry, but is associated with more rapid progression to advanced sight loss. Okay, brief pathogenesis about ARMD. In ARMD, there is atrophy of retinal pigment epithelium, which leads to deposition of drusen or extracellular debris between the Bruch membrane and RPE. And then the drusen will reduce the blood flow from the choroid to retina, causing the nutrients cannot reach the retina from choroid, and waste product from retina cannot pass into the choroidal bed. And then the RPE and photoreceptor will become ischemic, and that's when the dry ARMD occur. And if the ischemic of RPE and photoreceptors cause the break in the Bruch membrane, then the blood vessels from the choroidal circulation will grow into the retina and cause new vascularization and subsequently leads to wet ARMD. Okay, next. Okay, this is the flow chart of pathogenesis of ARMD, which I had explained just now. Okay, next. Next. Okay, this is the visualization on clinical manifestation and pathology of ARMD from the early to late stage. In early dry ARMD, we can see medium-sized drusen, and then in intermediate dry ARMD, we'll show the presence of large drusen, and in advanced dry ARMD, we'll show presence of geographic atrophy. So geographic atrophy is defined as the deterioration of the retinal pigment epithelium, photoreceptor layer, and choroidal capillaries in the macula. And then the wet ARMD shows invasion of abnormal fragile choroidal blood vessels, which grow from the choroid into the retina, which leads to blood and fluid leakage. Okay, next. Okay, this is the fundal image of ARMD. In image 1, we can see is a normal retina where we can see that the macula appears darker than the surrounding retina because macula has a higher density of retinal pigment epithelial cells or RPE. And in image 2, shows the intermediate stage of dry ARMD where we can see fine dark brown spots which represent the retinal pigment epithelium changes or abnormalities, and also we can see the yellow spots which represent the drusen. Okay, and in image 3 shows advanced stage of dry ARMD where we can see the central atrophy of the retinal pigment epithelium and photoreceptors, which we call as geographic atrophy. And last image, image number 4 shows wet ARMD where we can see calcified drusen, and then subretinal bleeding and some choroidal neovascular membrane which had turned black from whole blood and fibrosis and dark pigments in the macula. Okay, next. Okay, this is a clearer fundus photo of dry and wet ARMD. Here we can appreciate the drusen, which been shown as the yellow spots, and then we can see the central geographic atrophy and then some pigment clumping, and also in wet ARMD we can see subretinal hemorrhage. Okay, that's all from me. Thank you.
Okay, next we will proceed with the diagnosis of the ARMD, which in early stage, patient will not have any symptoms, and patient may not be aware of any visual disturbance if only one eye is affected and the other is seeing well. And then there will be gradual reduction in central vision of both eye, which will appear as fuzzy and shadowed image, and this will affect the ability to read, recognize face, and to see clearly in the distance. And there will be also mild distortion of central vision, which is metamorphopsia, which both near and far and straight lines may appear. And for dry ARMD, it will present as there will be drusen region and also atrophic changes like what Afifa has presented just now. And for wet ARMD, there will be appearance of drusen in macula and also the atrophic changes and choroidal neovascularization, and also the exudate of serous fluid or blood in subretinal or sub-RPE space.
No, Hazira, how
Yes.
do you monitor metamorphosia? Do you know how to identify metamorphosia?
Is it using the grid test,
Yes.
doctor?
Amsler chart, huh?
Ah.
Have you seen an Amsler chart before?
Um, From the textbook, yes.
Okay, when you go to the clinic, try to see, ask for an Amsler chart and see how it is. So we'll give that to the patient, especially with dry AMD, and then we'll ask them to hold 1 meter from, 1 hand breadth away, and then that lines will appear to be wavy, or there'll be a scotoma. Okay, usually for dry AMD, you can see metamorphosia. And usually wet, sometimes they'll have dry AMD. If it's in the atrophic stage, you'll have poor vision lah. But in the early stages, and for the wet AMD, usually they'll come with a poorer vision. So the next time you go to clinic, you just ask for an Amsler chart and see what is it lah. Okay, and proceed.
Okay, doctor. Next. As for investigation, sorry for the slide. Okay, the investigation include the wide field imaging in form of fundus fluorescent angiography, which is sometimes augmented with ICG. This is to confirm the presence of an area of choroidal neovascularization at the macula, and this use the dye. And also wide field imaging in form of optical coherence tomography (OCT), which is useful in diagnosis and monitoring the macular pathology. And the last one is fundus autofluorescence. This one use naturally occurring fluorescence from retina instead of injecting dye like FFA.
Okay, kalau examiner tanya which investigation yang you nak the most? Ni pilih dua.
Fundus fluorescent angiography.
Okay. Yeah.
And the ICG.
Okay, salah. So
Okay.
everyone get a clear picture. First, kalau patient datang dengan AMD, suspect AMD, kita akan buat OCT macula dulu. Okay. OCT macula ni bestnya compare dengan fundus fluorescent angiography. OCT macula ni dia non-invasive. Okay, nanti kat klinik you all observe ada satu machine ni. It's a very expensive machine. Basically dia macam CT scan tau. CT scan tapi dia CT scan dia at the level of your nerve fiber, at the level of your retina. So imagine we have a scans there at the clinic. Kita boleh buat scan, we can see at the level of nerve layer which level is affected and where does the fluid accumulates in which level. So OCT macula is diagnostic test as well as used to see any progression. Very important tool in diagnosing a retinal disease such as macular degeneration. So number 1 is OCT macula. Number 2 is fundus fluorescent angiography. Fundus fluorescent angiography ni again dia macam angiography where we put a dye in your body, macam kita boleh kita ada tengok yang jantung punya kan. Yang tu apa panggil dia? What is that? Most of the scans dyes tu you inject, you tengok kat jantung, you buat CT angiography, you tengok vessels dekat brain, you tengok vessels dekat heart. Yang ni kita boleh tengok vessels in the retina. Kita boleh characterize the vessels, we can see clearly. And then we don't need a radiologist ataupun we don't need ada subspecialty lain untuk tolong kita buat. Kita buat sendiri. So we inject a dye kat granula and then kita pakai mesin yang the same machine macam OCT tu. Kita take many pictures, kita tengok dye tu pergi mana, the vessels appearance macam mana. Okay, I would consider fundus fluorescent angiography ni in all cases of macular degeneration Especially wet wet AMD memang kena buat. Kalau it's best lah, it's best to do. But you know, things are changing. Kita more of sometimes when we see OCT macula tu, kita dah boleh tahu dah ni wet AMD, then kita proceed with treatment. Okay, so to highlight to you all, the most important investigation is OCT macula, non-invasive, and then followed by fundus fluorescent angiography, which is invasive. Alright, continue.
For management, management for patient with ARMD include zinc supplement and antioxidant vitamins, which is to lower risk or halt progression of dry ARMD. And then second one is laser photocoagulation, which is effective in sealing leaking or bleeding subretinal vessels in some eyes with exudative macular degeneration. This can prevent further loss of vision, but it did not restore the vision. And next one is surgery. Includes submacular surgery, macular translocation, and RPE transplantation. And then intravitreal agent treat exudative AMD by inhibiting the VEGF. And then rehabilitation for blind or partially sighted by home visit by low vision therapy to assess disability, contact with self-help groups. Then last one is low vision aids, which use optical aids such as magnifier or telescope, non-optical aids such as lighting or large print books, and electronic aids such as CCTV.
Again, I nak tanya. So which of this treatment yang you prefer the most? Saja je lah I nak tanya.
I think
You,
this one would be the
surgery.
supplement and
Apa?
surgery.
Apa dia?
I think this one would be kalau early stage would be the supplement and antioxidant vitamins, and then if the late stage baru surgery.
Okay, alright. The way you answer, it's good. Tapi early stage is what? Supplements. Supplements. Okay, apart from supplements ni, we also advise patient to avoid sunlight, you know, pakai sunglass. Okay. And then stop smoking, eat a lot of green vegetables. Okay, green leafy vegetables, high antioxidant diet, macam omega oil, semua tau. Yang tu basic you kena inform and educate and your family members, your patients, okay, about AMD, because AMD ni almost all of us will get eventually when we reach about 70 to 80. So the prevention starts now. And if you ada family member yang ada, you must educate diorang. Okay. Number 2, jangan jawab surgery. Okay, sebab surgery ni, first of all, macular translocation ni semua memang tak pernah, I think tak pernah buat. Ataupun pernah buat pun Mak Saleh buat mungkin 1 kali je kot. Memang diorang ada mention macular translocation, RPE transplantation ni semua jangan mention. The only answer yang I nak dengar is intravitreal agent. Intravitreal anti-VEGF. Okay. This one mesti Prof Zul akan tanya you all ni. This is the treatment, it's a gold standard current promising treatment untuk AMD. Okay. Untuk wet AMD. Intravitreal agent. Okay, everyone mesti dapat catch ni At the end of the lectures, everyone must have this idea. And not surgery. Okay. Laser photocoagulation, you boleh cakap laser therapy, but it's quite advanced. But if you were to ask these questions, you can say general measures include vitamins. Ada vitamins tau, specific vitamins untuk AMD ni. Because if you have a one eye moderate AMD, misalnya you ada moderate AMD in one eye, then you want to prevent the other eye to get the same disease, you can ambil vitamins. Ada study memang buat. Vitamin apa tu Sarah?
I think B, C, beta carotene.
Yes, yes.
Tapi beta carotene they exclude already. Sorry. B and C.
Yeah. What's the brand name of the vitamin? I lupa. Vitalux.
Vitalux, yes.
Yeah. So it's Vitalux. You ada vitamin untuk AMD ni. Kalau patient tanya you all kan. So okay, general measures and specific measures. General measures like I mentioned just now. Specific measures go for intravitreal anti-VEGF dengan laser. Okay, no surgery. Alright,
Okay.
continue.
Okay, Doctor.
Good morning to doctor and everyone. Bushra and I will be presenting for the last topic, that is diabetic retinopathy. So I will start off with it. So we will talk about proliferative and non-proliferative diabetic retinopathy. We are not going to discuss about the diabetic maculopathy. Next slide, please. Okay, so I just go through the overview of what means diabetic retinopathy. Diabetic retinopathy, as from the name itself, we can know it's a disease of retina in presence or caused by diabetics condition. So it's a form of a microangiopathy, which is a small vessel disease causing damage. It causes damage to the small blood vessels of retina as a result of hyperglycemic condition. And the risk factor for a person to develop diabetic neuropathy is the duration of diabetics. For example, those who have diabetic type A, they are more prone to get diabetic retinopathy. But diabetic type 2, which is asymptomatic, and during the onset is usually not detected. So it will be detected later. So the duration of diabetics is really important when tracking the patient to know the risk of them developing diabetic retinopathy. And poor the control of the glucose level in a patient. So for example, the patient who has a poor glucose control, they are prone to develop a diabetic retinopathy and those with hypertension are also a risk to develop diabetic retinopathy. And those with renal disease, hyperlipidemia, those who smokes, and those who are obese, and in pregnancy, for example, those women who are pregnant with underlying of diabetic, not are prone to develop diabetic retinopathy in pregnancy, as we know in pregnancy, due to the hormones, their glycemic level would be high. And for example, those who in pregnancy, those who are diagnosed to GDM, they are not prone to get diabetic retinopathy. Next, please. Nazla, next, please. Okay, for the diabetic retinopathy grading, so it is like it is graded. It's staged into 4, which is mild, non-proliferative. It's divided into 2. One is non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. The non-proliferative diabetic retinopathy is subdivided into 3, which is mild, moderate, and severe. For the based on the ophthalmology, based on the fundoscopic findings on the ophthalmoscope, is that for mild non-proliferative diabetic retinopathy, it is only microaneurysm will be detected. While for the moderate one is that more than microaneurysm, but less severe non-proliferative diabetic retinopathy. For example, the patient would be presented in those who presented in moderate non-proliferative diabetic retinopathy. They would on their fundoscopy finding, they would have microscopic, then they would have a dot and blots, hemorrhage, and then presence of exudates, but it would be less severe. It will be less than the presentation in the severe. For in severe, it follows this criteria that follows this 3. If they have any of the following, like for example, they have in the fundoscopic findings, they have more than 20 intraretinal hemorrhage. For example,
in each of the four quadrants. And second is definite venous bleeding in two or more quadrants of the fundoscope image. And third is the prominent intrarenal microscopic abnormalities, which are IRMA, in one or more quadrants, and there's no sign of proliferative retinopathy. What are the signs of proliferative retinopathy based on the fundoscopic finding are: the moment a person presented, the person has findings of neurovascularization and vitreous or periretinal hemorrhage, they are diagnosed to have proliferative diabetic retinopathy. Okay, next, please. So this is a normal picture of the fundus of a right eye. So there is the optic disc and macula and foveolae. So in order to know an abnormalities, we need to know the normal one. So next, please. So just now I said about microaneurysm, right, which is presented in only the mild non-proliferative diabetic retinopathy. So microaneurysms are actually the early signs of diabetic retinopathy. But usually, since I just want to say something that in diabetic retinopathy, the symptoms, the patient will usually be asymptomatic. Usually in the late stage of DR, they will present with the symptoms like floaters and blurring of visions and gradual loss of visions. So usually they will be asymptomatic. So the person who started to develop DR, the early sign would be having a microaneurysm. So what is microaneurysm? Microaneurysm is as in the scope in the fundus image. You can see it's like a tiny red dot. It is actually an follicular secular dilatation of capillary walls where the pericyte are absent. And the next would be the dot and blotches, which is now we follow to the second second subtype of the non-proliferative diabetic retinopathy, which is they would have a microaneurysm. They would have more microaneurysm and other features, but not as severe. The presentation as severe in the severe non-proliferative diabetic retinopathy. So dot and blotch hemorrhages arises from bleeding capillaries in the middle layer of the retina. So this is an example of it. Next, please. And the next is for the exudates. Exudates, we have soft and hard exudates. So for the soft exudates are the cotton wool spots, which appears as a small fluffy whitish superficial lesions on the fundoscope image. And then for the dark exudates they are discrete and yellow particles within the retina. Next, please. So for the other type of hemorrhage is the flame-shaped hemorrhage. These hemorrhages are diffuse and usually found in the posterior pole of the eye. And then for the just now I mentioned about the presence of IRMA, which in the severe non-proliferative diabetic retinopathy is actually a shunt vessels that appears as abnormal branching or dilatation of existing blood vessels capillaries within the retina that act to supply the areas of non-perfusion in diabetic retinopathy. Next, please. So for the proliferative diabetic retinopathy, it will be diagnosed when there is two features in the fundoscope image. That is neovascularizations, or there is any vitreous or periretinal hemorrhage. So for neovascularization, is that it will be in the new. We have to look into it whether it's there's new formation of new vessels around the disc, or at the new vessels are formed at everywhere else. Next, please. So for the other features of the fundoscopic image of the proliferative diabetic retinopathy are the vitreous hemorrhage if the patient has a vitreous image or periretinal hemorrhage. So periretinal hemorrhage are actually boat and T-shaped hemorrhage, and while for the vitreous hemorrhage it bleeds into the vitreous cavity, is seen as fresh blood clots with sudden onset of floaters. So these are the images of the vitreous hemorrhage and periretinal hemorrhage. Next, please. So to differentiate between the non-proliferative diabetic retinopathy for fundoscopic image and the proliferative diabetic retinopathy fundoscopic image, so you can see in the non-proliferative diabetic retinopathy, there are we are taught there are cotton wool spores, microscopic aneurysms, and flame shapes, as I have placed a picture on non-proliferative diabetic retinopathy, but there's no any new vascularizations or periretinal hemorrhage or new and then for the proliferative diabetic retinopathy, this is the example of the patient who has proliferative diabetic retinopathy. That is they can have all the have all the findings that can be presented in non-proliferative diabetic retinopathy, with an additional of new blood vessels formations at the optic disc. For this picture, new vascularization is presented in proliferative diabetic retinopathy, as shown in this picture. Next, please. So to diagnose diabetic retinopathy is most of the patient would be unaware of their symptoms, as mostly it is asymptomatic, as I said, unless they presented with late symptoms or sight-threatening diabetic retinopathy. And the mainstay of the diagnosing diabetic retinopathy is a complete ophthalmic examination, starting from the visual acuity to the fundoscopy, and dilated retina examination by an ophthalmologist or retina specialist or retina surgeon. And the screening of diabetic retinopathy is essential for early detection and for early treatment to prevent the progression into the to the latest advanced stage of diabetic retinopathy. So these are the screening years and the according to the categories and the years. Like for example, this is according to the CPG of screening, that adults with type 1 DM who are diagnosed with type 1 DM, they need to be screened up to 3 years after diagnosis, and adults with type 2 DM at the time of diagnosis, because usually, as we know, as I said earlier, type 2 diabetics is during the early onset, we wouldn't really notice, the person wouldn't really notice it, so they don't know how long they have been having type 2 diabetic mellitus. So for pregnant women with pre-existing DM prior to planning pregnancy, and children with type 1 DM at the age of 10 or onset of puberty, if this is earlier, after 2 to 5 years of diabetics durations, and annually thereafter, and children with type 2 diabetics at the time of diagnosis. Next slide, please. That's all from me. Thank you.
So I will continue for the investigation and management. For investigation, we can order the blood glucose and HbA1c test because we know that diabetic retinopathy will develop after the prolonged diabetes. And then second one is the fluorescent angiography. This test can show any abnormalities within the blood vessel. So for the microaneurysm, it will appear as pinpoint and hyperfluorescent lesion. And then for the blood and dot hemorrhage, it can be distinguished from the microaneurysm as it appeared as hypofluorescent. For the intraretinal microvascular abnormalities, it can be evidenced by the collateral vessels that do not leak, and this can usually found in the borders of the non-perfused retina. The neovascular will appear as leakage because the fluorescent dye because of their high permeability. So they will start as perfluorescent areas, and then it will increase in size and intensity in the later phase of the test. And then optical coherence tomography, which is OCT, it is administered to determine the thickness of the retina and also any presence of swelling within the retina, as well as vitreomacular traction. This test is particularly used for the diagnosis and also management of the diabetic macular edema or any other macular edema that not caused by the diabetes. The last one is the B-scan ultrasound. The ophthalmic B-scan ultrasound is most useful in diabetic patients with vitreous hemorrhage or other media opacities, where the retina cannot be visualized directly during the ophthalmic examination. Okay, next.
Okay, jap. Okay, investigation. Okay. You can okay, pick one investigation yang you nak. Kalau you dapat case diabetes.
I would say fluorescent angiography.
Okay. Alright. Again, misconception, everyone. You need untuk diabetic retinopathy ni, it's a clinical diagnosis. Okay, you don't need, and then you don't say fluorescent angiography sebab fluorescent angiography ni is actually invasive and it's not without side effects. Patient can have a severe anaphylaxis because of the dye, and then patient in fact can get into a renal impairment. So in clinical setting, you can start to train now. You always go for a non-invasive test first. You would want to say OCT first. Okay, like I mentioned just now, in a retinal cases, you always want OCT first as your tool, as your supportive tool to help you diagnose. And then OCT in diabetic retinopathy only apply if you are the diabetic maculopathy, which is not covered here in this lecture. You need to cover diabetic maculopathy. It's very common. It's one of the cause of a visual impairment in a diabetic patient. Like first presenter mentioned just now, they don't come with symptoms, diabetic retinopathy, until at late stage where it has already bleed, vitreous hemorrhage, boat shape hemorrhage, semua tu kan. Itu patient akan datang dengan simptom, dengan floaters. Tapi kalau diabetic maculopathy, dia akan datang lebih awal. Dia akan dapat impact in near vision dengan distant vision. Dia ada accumulation of hard exudates over the macula. Nanti I want you all to go back and baca about diabetic maculopathy. Diabetic maculopathy ataupun diabetic macular edema. So this is where the OCT helps in the diagnosis of and treatment of diabetic macular edema. Okay, FFA tu kita tak buat sangat unless patient tak ada dapat treatment daripada FFA ni. Kalau kita tengok patient ada diabetic maculopathy, kita bagi treatment, dia tak improve, barulah kita buat FFA, but it's rarely kita buat. And then B-scan, good. You mentioned B-scan, kalau the patient ada full visual vitreous hemorrhage, media opacity, very dense cataract, you don't see anything, you do B-scan. Alright, your blood glucose, good. You need to take one, and usually memang patient akan sky high lah datang. Time tu lah first diagnose diabetes, glucose 18, memang banyak. So, alright, next slide.
Okay, for the management of diabetic retinopathy can be divided into general management and specific ocular management. For the general management, first we need to educate the patient because the patient education is important to ensure that they understand the disease, so they need to comply with all the treatment schedules. And of course, diabetic control should also be optimized. And then other risk factors should be controlled, particularly in the systemic hypertension, especially in the type 2 diabetes, and also those with the hyperlipidemia. I'm not sure about this, but consider to prescribe fenofibrate, which is lipid lowering drug, because it's shown that it can reduce the progression of the diabetic retinopathy in type 2 diabetes. And then advise, if the patient is a smoker, advise the patient to stop smoking, because smoking may cause vascular damage and also may make the patient more resistant to the insulin. Okay, next. For the ocular management, the first one is the panretinal photocoagulation, PRP. PRP is the preferred form of treatment for the proliferative diabetic retinopathy to reduce the risk of vision loss due to the vitreous hemorrhage or tractional retinal detachment. So how it done is it involves applying the argon laser that burns over the peripheral retina, sparing the macula, papillomacular bundle, and also optic nerve head. So this will cause the regression of the new vessels at the optic disc and the new vessels as well. Must attend the patient that they might temporarily have reduced peripheral and night vision post PRP. So once the adequate laser has been applied and the abnormal vessels will regress in about 8 weeks. The second one is the macular laser. The patients must be warned that the macular laser treatment is used to prevent the vision from getting worse and does not always improve the visual acuity. There are two types, the focal laser and the grid laser. And also for the side effect, some patients may notice a scotoma after the macular laser treatment. Next is vitrectomy. This is a specialized procedure whereby the vitreous is removed via a transplanar incision or TPV. So the indication for vitrectomy are to clear the vitreous hemorrhage so that the surgeon can visualize the retina and apply for the PRP laser. Also to relieve the retinal refraction and repair the retinal detachment. And last one is to treat the diffuse macular edema due to the vitreous traction. And the last one is the anti-VEGF injection so that it will reduce the proliferation process. Okay, that's all from me.
Okay, all right. So management wise, I like to divide into laser treatment, injection, and also surgery. In terms of management, is Sally, can you go back one slide, previous one slide? Okay, it's best kalau you cakap management of diabetic retinopathy depends on the stage of diabetic retinopathy. Kan kita ada mild, moderate, severe and also proliferative diabetic retinopathy kan, and also advanced diabetic eye disease. Alright, so the management depends on stage. Macam mild NPDR, kita akan monitor every 9 to 12 months. Kalau moderate NPDR, kita akan monitor every 6 months. Kalau severe NPDR, kita akan monitor every 3 months. When patient have proliferative diabetic retinopathy, PDR, kita start laser treatment. Okay. And then when patient have diabetic maculopathy, I cakap tu, diabetic maculopathy can happen at any stage. Can happen at mild, moderate, severe or PDR. Kalau patient ada diabetic maculopathy, you give laser treatment. Okay, laser anti-VEGF. Sama macam ARMD tadi. Dan, okay, and then subsequently kalau patient develop advanced diabetic eye disease, patient perlu undergone vitrectomy. Okay. This is the general idea and the most important management. Ocular management. Okay. of course, you need to manage the patient as a whole, manage the patient systemic condition, refer patient to medical department ataupun endocrinologist to manage, to control the diabetes. And then the rest would be like stop smoking, weight, exercise, diet, like you mentioned here. Okay. All right, Sarah, any comments, Sarah?
Yeah, like Abbas said, we have to control the primary disease, and if the patient has high risk factors like just now the presenter was saying about like diabetes, pregnancy, and patient has plans to go for cataract surgery, then the control has to be higher, and suspicion of progressiveness of the diabetic retinopathy itself, you have to pay attention to it lah.
All right, this is the last slide kan. So I thank you all for taking your time to prepare a well written slide. Memang very advanced. I mean very concise and covered major topic.
Hello, Abbas.
Hello. Yeah.
Tak dengar tadi.
Oh, okay. So very concise.
Hello. Hello, orang lain boleh dengar ke?
Boleh doktor.
Oh, suara Abbas dengar lah. Suara Dr. Abbas dengar ke?
Tak dengar.
Kan?
Tak dengar suara Dr. Abbas.
Okay. Saya rasa okay, tak apa. But really very good presentation, very concise and very good slides. So keep up the good job and thank you. Okay, we end our session. Okay, very good. Okay. Bye bye.
Thank you, doctor.
Thank you, doctor.
Bye.